welcome. We have a special program this afternoon, 5 p.m. on the East Coast. We know it's a little late on a Friday, but we wanted to welcome you all to our AAN Academic Initiative webinar. We've done a few of these, and I hope some of you have been to our prior ones. And today we're going to be specifically focusing on some financial issues. We've set these up through our academic work group to really focus on ways to help our fellow department chairs, our academic BAs, and other members of academic departments as much as possible. We've done a few of these now, and hopefully you've seen some. We focused a lot on COVID-19, and first one in April was best practices for inpatient services. And then in April 17th, we heard directly from a number of New York City chairs on COVID-19 and how they had been dealing with the surge and dealing with interdepartmental communication strategies. Next slide. Then we did two others. One dealt with kind of reactivation and dealing with activities, clinical operations during the post-COVID-19 surge, even though, as you know, some other surges have occurred since then. So some of these things are still relevant. And then Andy Josephson actually chaired the one for webinar 4 on education and training. We did pivot on the fifth one, and the last one was a very special webinar that was focused on specifically addressing systemic racism. And as you know, the Academy is taking on this in a big way. We've had a commission to focus on moving the Academy further and our whole field to be an anti-racist, both organization and field. And so there will be some recommendations that will be coming soon to the board from a special commission and task force that we hopefully will let you know more about in the future. All of these have been recorded, and they are on AAN.com, on the AAN YouTube channel. If you weren't able to attend, please take a look at the recording, just like today's will be recorded. Next slide. So today, the focus of this webinar is one really dealing with financial repercussions. And, some of the themes will be relating to COVID-19 and, what has happened in affected departments in terms of both revenue, bottom lines, and then obviously expense reduction. And you'll hear from a variety of different people from different departments on this. I think even though we're focused on, the repercussions of COVID, some of these still lessons would be helpful to all of us when we manage budgets in department. As you know, the AAN initiative has also helped publish an article on funds flow that Andy Josephson led, and we have another article we're working on that'll be coming out soon regarding funding the educational mission. So that's been a big focus of our group and our academic BAs to deal with the finances of academic neurology. Next slide. So just in introducing our panelists, we basically have tried to hear from chairs and their academic business administrators. So I have David Greer, who's department chair from Boston University, and Sheila Fasil from the administrative director. And then from Texas Tech University Health Sciences in El Paso, Salvador Cruz-Flores, who's department chair there, and Vinny Kaur, who is the senior clinical department administrator there. Next slide. Also joined by UCSF, Andy Josephson, who's the department chair at UCSF, and Jane Check, who's the associate chair of finance and administration, and Jane is one of the leads in our academic business administrators work group. And then I'm here to help moderate from the Department of Neurology, and my vice chair was supposed to join, but we are getting ready for a possible hurricane here, so she unfortunately couldn't make it. And then University of Wisconsin-Madison, we have Kathleen Shannon, who's department chair there, and Greg Zalesak, who's the administrator there. So welcome to all my panelists. So as you know, most of you are out there and part of academic departments. COVID-19 has put a tailspin into certain financial projections. Not sometimes directly for departments, but sometimes indirectly. For example, in Miami, when we were preparing for the first surge, we cut back on all elective admissions. A lot of surgical cases were stopped. So the whole revenue flow to the institution took a really nosedive. And in fact, they were saying we were probably losing about at least $1 million a day to the bottom line. So, these were direct hits to the whole, academic health system. Some of them more directly to neurology than others. Seeing ambulatory cases took a hit since we weren't able to see people in person. with the concerns in COVID. And so this was a major financial effect to all departments. I was recently, even a question came in regarding EMU and other procedures that are neurology relevant, brain tumor surgery, deep brain stimulation. All of these things were placed on hold and obviously began to affect the bottom line for a health system. So during that, there were things that we had to do during the surge, and now, of course, in the recovery phase, what is going on, and as well as some that are having resurgence. So we thought we would split this up into two parts. The first part is let's focus on the positive. What has been done in a big way to really help bring in revenue to departments? And so we'll focus on the revenue for the first set of questions, and then we're going to move a little bit more on the expense reduction side, cuts, but we always try to first think about the positive is bringing in revenue. So some of the big things have been telehealth, so our focus is a little bit there. So I wanted to turn to Andy and Jane from UCSF and talk a little bit about, can you describe some approaches on how your department increased revenue during the COVID-19 surges, particularly maybe on some non-telehealth approaches, and then we'll move a little bit into telehealth. Andy?
Sure, Ralph, thanks for having us. You know, I think our department has done what so many have done, which is just figure out how can we maximize revenue with an eye to helping as many patients as possible. And as you said, telehealth was a huge part of it. I think some other pieces on the clinical side were that we had a number of our physicians who volunteered in our respiratory screening clinics next to our internal medicine physicians, and a number of those of us who were in neurocritical care who worked in the COVID-only ICUs. These were all on a voluntary basis, but were, you know, an opportunity for folks to increase the number of people that they are able to see and help the health system in general. In addition, as we've moved to recovery, we've tried to, you know, we've got this big backlog of patients and big backlog of procedures, as everyone has. And so we've tried to fit those people in, often on evenings and extended hours on weekends. And, you know, we don't know our finances on the clinical side at the end of the year, but it looks like work RVUs for the year really only about 2 or 3% off, which we're just thrilled about. And most of that is the hard work in late May and June that we were able to do. There were also a number for individual physicians, some leadership roles they were able to take on organizing this recovery for the entire health system. And I think I could say the same thing on the educational side. Some of our clinician educators were able to take a role, for instance, leadership in planning the new medical school clerkship arrangement across multiple specialties. And then finally, you know, we're a department that's probably about half clinical, half research. We've seen actually an even larger number of proposals submitted. I guess a lot of people are around and able to write, which has been great. And then a number of laboratories and clinical research that have pivoted to a COVID neurology focus. Those have all been really fairly successful strategies for us. Jane, I don't know if you had anything else that you'd want to add to that, but those have been our revenue sources going forward.
Yeah, I think as a department, we're very diversified. So we have the clinical, but we also have the research revenue, which actually increased during this time in terms of proposals submitted. Some very fast turnaround times on getting dollars in for COVID-related research. We took advantage of that and are continuing to do that. We have a lot of biotech in the area, so we've really taken advantage of partnering with others. Philanthropy, we were very concerned about that initially, but I think Andy could say that people have continued to want to give. So that has also been a continued source. I know the telehealth and the clinical is always a big question on recovery. And at UCSF, we've always been very metric driven. We're always given a lot of information and dashboards, everything we could possibly want to know. So there was a close tracking of external and internal referrals, and they dropped to about 25%, but now are up above pre-COVID levels. And then just as a kind of a point of reference, I looked at the distribution of visits from 1 week, July 19th to 25th, and of 988 scheduled visits, 57% were follow-up video and 9% in-person follow-up. And then there was 6% in-person new patients. When I talked to the practice manager, she said that they probably expect to continue 25% telehealth into perpetuity.
Yeah, I
Just
think
a
the
little bit.
telehealth, and we're going to pivot to that in a moment, is here to stay. One quick question to Andy. You talked about your kind of repurposing of certain faculty, the neuro ICU becoming a COVID. So when you show the important impact of your faculty to the whole system, that's helpful for financial. One thing that's come up in our place, for example, were you paying overtime or overloads for those hardworking neuro ICU people running now a COVID unit?
Yeah, in our case, we didn't, because it was just an opportunity to do the same work you were scheduled to do for the most part, but there were no neuro patients to see in the neuro ICU for a period of time there. So it was a little bit sort of pivoting your shifts. For those people who worked in the respiratory screening clinic, more of a sort of an elective piece, they indeed didn't get overtime, but those RVUs that were generated were sort of paid to them over what they normally would do. So our system, our funds flow system, sort of allows extra work to always be paid as extra pay. So it was an incentive for people to do so. And many of those screening clinics, some were in person, some were by video.
Perfect. And then also the CARES Act. I know each of us, some of us more than others, and even in Miami-Dade, there was some recent scuttlebutt happening. The vice president happened to be here, and somebody raised, we didn't get as much care support. The next day, a check was in the mail, but whatever. Did you receive some CARES Act funding for your institution? Jane,
We did, yeah.
You did, and that has helped at least the whole institution, probably not
Yes,
directly.
it doesn't come down to the department, but of course, what helps the institution helps all of us, yes.
Right. And we did too, and that is helpful. Let's pivot now a little bit now to telehealth, and we called it virtual neurology telehealth. It was a huge savings. I know at our place, we were able to quickly pivot up, and I think we are hitting now almost 90% of where we were with a lot of telehealth. I wanted to hear from Kathleen and Greg at Wisconsin about their experiences with virtual neurology. Has it helped make up for some of the reductions in your ambulatory revenue? Kathleen? Oh, you have to unmute.
I'm unmuted, yes. So our pivot was not quite so smooth as yours, Ralph. So what we did do, we didn't cancel any of our outpatient clinics. We did pivot down our EMGs to just essential ones, and we didn't have elective, we didn't have EEGs unless they were essential either. But as far as our outpatient clinic, we didn't cancel any patients. We immediately switched to telephone visits. And the reason is we did not have a robust telehealth platform at UW. But the telephone visits actually worked fairly well. There were some glitches regards licensing, because we see a lot of Illinois patients, and the Illinois license wouldn't let us see return new patients over telephone. But we saw many new patients and return patients in general over telephone. And we continue to do some in-person blocks and botulinum toxin injections and LPs that were emergent. And the issues for our telehealth platform was we had an EICU and we had telestroke. So these were cart-based kind of telehealth systems, but we did not have a platform apart from a direct-to-consumer primary care model for really minor issues. So we didn't have the luxury of picking the best platform. We went with the platform we already had for these direct-to-consumer calls. But I will say, and we also didn't have the equipment. So our office desktops don't have webcams. Our clinic desktops don't have webcams.
Right.
We had to really get a lot of tablets and other devices in hand quickly and then train people. But once we shifted over, for the most part, telehealth has been good. We're in a rural state, so a lot of times the remote bandwidth is poor. And so we would have to change to a phone visit. But I have to say that the satisfaction for telephone and for video visits was quite good, and many of our providers found them extremely satisfying. And we do plan to go forward with televisits, but there's an institutional effort to find a better platform. So that's kind of in flux.
Well, you know, it's interesting at our place, we had a large no-show rate. Many people didn't show up for their appointments when they were in person. That plummeted when we went to virtual neurology. Headache and Alzheimer's, for example, they were doing almost 100% were making the appointments. So once they could figure out all the connections. Greg, from your perspective, what about any challenges with telehealth? I know the platform was an issue, but any other challenges at Wisconsin regarding pivoting towards virtual neurology?
Yeah, as Kathleen mentioned, there was some issues with licensure earlier in the process, but that was resolved relatively quickly. I think that there was prior apprehension before COVID as to how patients would accept telehealth.
Yeah.
With COVID, we found that the acceptance was very widespread, and that actually had situations where if a patient had the option of coming in for some of our limited in-house visits versus telehealth, many patients actually preferred doing the telehealth option in the beginning of COVID. Initially, our practice plan, in order to ensure that we had a relatively smooth transition, was holding the bills for telehealth until systems were set in place to be able to process them. What we're actually seeing as far as revenue and RVUs, we did very well. We compared to last year, we did not see as dramatic a drop-off as I thought we were going to see. And telehealth, I think, is presenting us with an opportunity in a lot of different ways. I see it as giving us an option to improve our clinic access because the visits are shorter, patients are as you said, making the appointments when it's a telehealth visit. It's really has helped us expand the neurodiagnostic services that we're offering to hospitals across the state. And we're seeing it as an opportunity to also kind of revamp how we're doing our regional clinics, because we have clinics that are spread throughout Wisconsin, and found that the patients in those locations have been accepting of having the visits done via telehealth, rather than having a neurologist drive 2 hours to a community hospital for a day or so each month to see the patients. And then the final thing, although it hasn't impacted us as a department specifically, is that it's given institution an opportunity to take a look at space rental. They have a pretty extensive rental of space across our community here. And telehealth is allowing them to take another look at that, perhaps reduce some costs there and have some savings.
So you know the Academy has been a big push in terms of the advocacy for continued payment for telehealth services, which are covering now both telephone, the virtual video link, CMS, as well as non-CMS players. And I'm told that will be continued. The latest we've heard, even in the two CARES Acts that both the Senate and the House have, the extension of those payments through at least this calendar year, and we hope even further are in there for CMS and other payments. So the payments, I think, are important, and that's been a bit of a lifeline for departments of neurology. David and Sheila, I wanted to talk about, sometimes we have a pressure because many of our institutions have hospital-based clinics and there are facility fees, and sometimes institutional officials want the people to come in person because of those facility fees, which I believe you don't have when you're on the phone. Have there been any institutional pressures for you to kind of move away from virtual visits due to this lack of facility fee? Or how have you handled that, and what has been the administration's sense with your pivot to virtual neurology? So David and then Sheila.
Yeah, we really haven't gotten any pressure from the administration to try to get people in person. They understand the importance of keeping people healthy and uninfected, including not just the patients, but the faculty and the staff. And I don't think they ever intend on us getting farther than 50% of our original capacity. So they're very good about that. I think that everybody sees neurology as often an access issue. So however we can get patients seen, whether it's phone, video, mule, camel, whatever, we just need to be able to get the patients seen is important. And then very importantly, I think for the hospital is the downstream revenue, that if we see patients, we generate scans, we generate neurosurgeries. These are the things that really make the big bucks. And I think that at least our hospital administration, I think, is savvy enough to understand that we can do things however we can to provide the care give the access and then keep the main revenue stream going for the hospital.
You said 50%. So, I mean, just saying, we looked at, say, what we were doing in February, where we were doing all in person pre-COVID, and then what we're doing now, and we're actually hitting almost 85 to 90%. But with the virtual, you only got to 50, or has it been better?
No, our virtual is way more than 50 now.
Okay.
Our in-person, we started out at about 25%, and now we're going to 40%. And we brought back EMG and EEG because those are our revenue generating things. But now we are at 119% of what our pre-COVID volume was. Now that we're doing the telehealth visits as well. And I don't think we're going to stop there. Hopefully we'll get to like 150% because it's great.
Right. Yeah. And that's the other example of, and I know you haven't had a resurgence. So we were doing, and then we began to bring people in for EMGs, for Botox, because many of those were put on pause during our first surge, which was the mini surge. Now we're having a real surge. So then we had to then drop off again and keep the virtual neurology going. So our virtual neurology has stayed up pretty high. The procedures began to pick up, and now they're dropping off again. You can't do virtual EMGs, at least not yet, or EEGs, but that may be coming in the future. Sheila, what about from your perspective? Any comments about the handling of virtual neurology in the department?
Yeah, so we were actually able to pivot pretty quickly to virtual as early as mid-March. So we were seeing about 80% of our pre-COVID volume using virtual visits, primarily telephone in the beginning, but we started to increase the number of video visits that we do as well. And to your question about pressure from the hospital as far as facility fees, we're kind of holding our breath there for a minute, but it looks like our insurance companies in the state were continuing to extend and provide the facility fee to the hospital. So they've continued to be supportive of growing our practice and growing the volume, and we haven't really received any pressure from that perspective.
Anybody on the panel, anybody receive any pushback at all for virtual? Great. Yeah, and I haven't either in our place. It's been fine. And, patient safety and staff and faculty safety are critical, and that's another reason why I think we need to continue to push for virtual. Yes, David.
So I would just say that the facility fee should continue to come, and hopefully the legislatures will see that, because the administrative burden for us to schedule all these visits, including the telehealth visits, is tremendous. And so what it costs the facility to do that in terms of them paying the staff that work in the clinics is still the same. It's not like they can cut any corners and save any money on that. So
I don't know if they can charge it though if a person doesn't come to the facility. So in our places, there are practice-based clinics, even though they're on the hospital campus, and then there are hospital-based clinics. Neurology is a practice-based clinic, so we never had a facility fee. While neuro-oncology sits in the cancer center, that's a hospital-based clinic, and there are facility fees. But I think if you do virtual neurology, and help me anyone else here, you cannot charge a facility fee. Does anybody think otherwise? But you're right, there is extra work that gets to happen.
I agree with Sheila's experience that right now payers are paying the facility fee for the hospital-based clinics.
For hospital-based, yep.
That's what
So,
Sheila's
I think last question on telehealth, because I want to make sure we get to the other issues on some of the expense reduction side. I think we touched on this a little bit, but Vinny, do you want to tell us a little bit, have patients been happy with the telehealth? Any complaints about telehealth?
No, actually, I am really surprised. We do have a process internally whereby we are Joint Commission certified. So our clinics have to go through various workflow processes. We get complaints through various mechanisms that have been formally structured within the campus and the department. And when we do get it, we do look at it very carefully and bring it in internally and discuss it. However, since March 16th, I found that I have had no discussions on patient complaints. And so it's been very good for us. In fact, the patients have been very good.
I mean, other than sometimes having trouble navigating the computer systems and needing help, so we've got to repurpose our medical assistants sometimes to help them, calling in advance, getting them on. telling them which buttons to press and all that. But by and large, people have adopted reasonably well. Anybody else feel otherwise?
No.
No, I would just concur, Ralph. At our place, we see monthly across the entire health system patient satisfaction scores, and they're actually the highest they've ever been in the last 2 months in the setting of a big migration, of course, to virtual visits.
Great. David?
Not to be a fly in the ointment, but we serve an underserved population and many non-English speakers. And so I don't know that the satisfaction, has been assessed in that population. And I'm pretty certain that the care has not been as good via telehealth, just because the translation issues can be very challenging without network.
Well, that's a great question. I had actually was asked that, at our place, we do have a lot of Spanish speaking patients as well as faculty and staff, so it works. We do have translator services, but anybody else? Vinny, did you have a comment here? And I'll call on Kathleen in a moment. Vinny, then can you mute if not? We're asking about translation services, if you've needed them.
I can
Go ahead.
I can fill in for that. I mean, our population is about 85 Hispanic. We're right at the border, but at least half of the staff is Spanish speaking anyway.
Right.
We have few residents and a few faculty that don't speak Spanish, so we generally don't have any issues with translation. And the feedback from patients has been very positive, particularly those with disabilities and so on that had to travel a distance. The feedback has been generally pretty positive.
It's a great convenience. Kathleen, you had your hand up.
Right, so we don't have a very diverse population, but we do have a very robust interpreter services at UW. Yep. So, I've had Tibetan interpreter. And, so it hasn't been actually that difficult with multiple video hookups and or multiple people on the phone. Yeah.
Andy, go ahead.
I was just going to reflect what Kathleen said. We have a very diverse language population, and we have all of our interpreters who click on when you press a button. So it's me looking at the virtual screen, interpreter one, the other. And our sense is it's actually better for interpreter services because we're not in the room waiting for that person to show up who might be down the hall with another visit. It's actually, I think in our case, been a big success.
Great. So actually some Q&A is coming in a little bit. We're going to pivot in a moment to some things about expenses, but there was a question here. Oh, this is a good one. But for Kathleen, movement disorder evaluations by telehealth has been a particular challenge. So most of those have ended up coming for in person. I thought movement disorders would be great on video, but Kathleen, what do you say?
Well, the challenge was doing it on the phone, but I've starting to see people, we did arrange for people to come in person after, for their first follow-up after the phone visit, and I'm keeping track. And apart from someone who I had the cerebellar ataxia, right, but not the neuropathy. It's remarkable. We have to remember that we're very history driven in this business, and it really gives you great assurance that our histories still are the most important part of our diagnosis.
For us, headache and Alzheimer's and cognitive have done very well. Neuromuscular, it's been a little more troublesome. It's hard to really examine, over the virtual. Another question comes in telling us that at Penn, there is a facility fee for Medicare for telemedicine visits and in-person visits, and the facility fees are quite different, $26 per visit for Medicare telemedicine, and in-person is $122. So there's a $100 differential or more though. And then another good question here, how about your physician satisfaction with telemedicine? I know at our place, our physicians have been happy with it. They like doing it, but any pushback from physicians in terms of not feeling good about it? The question comes in, quote, is nice to work from home, but a day of telemedicine is, from most I've talked to, more exhausting than it has been when seeing a patient in person. Any thoughts there? Go ahead, Sheila.
So yes, I can speak to this. We were very deliberate about doing surveys as we were rolling out telemedicine, and we got feedback from providers about what was working and what wasn't working. And for the most part, people were satisfied and found that the quality of care that they were giving patients was satisfactory. Where we had challenges is that it was a very completely different scheduling workflow. And we were also using different technologies. Some of our providers were using Doximity, some of them were using Zoom. Patients also had differences in terms of how they were able to connect. So we had to do a lot of work in making sure that our scheduling workflows were as streamlined as possible so that the provider's experience could be a little bit better. And we have some work to do around that.
And workflow is a great one. For example, we decided not to try to do someone having an in-person clinic and then pivoting to a virtual and then an in-person and a virtual. We kept them sort of stratified, and our clinicians felt better about that because in terms of how things are running on time. Another question came in, a real specific question about visit times. Are they longer because of technology issues? You know, ones I've done haven't been, but anybody, do you feel like it's taking longer in a televideo? As long as you have your medical assistants doing things a little bit in advance, that's what we've done, and they help get the connection going and then connect us in, and we use through Epic, it's all set up for us. But any feeling that it's taking longer with telehealth?
Generally speaking, the visits have been more shorter, actually, more efficient. Yeah.
Remember, the telehealth are timed visits, so it can't be too short. But
yeah, I know that can be too short. That's true. But and it seems as if, at least the experience that we had is that it seems like patients focus more on the problem and what the questions they have, as opposed to extended conversations about other issues when they're in person. So this is where more efficient. But.
David, go ahead.
I'll give a contrary view. Mine are often very much longer because when I ask for the medications, because I like to go over the med list, because the MA is not doing it.
Oh,
that's when you really go into this, you know, hey Larry, go get my meds, and you know and they try to read them out, and like the pronunciation, you often have no idea what medication they're talking about. So that can really add a lot in my
that time. You're right. One last question here, then I want to pivot away. And it's a deal. It deals with a legal exposure, and the question really comes in about, you know, in terms of really adequately examining the patient, and what if we miss a certain sign? And the example here is missing an upgoing toe, and the MD didn't suggest an in-person follow-up. Are there any legal repercussions? Anybody heard of any? Particularly, I guess, you know, in examination findings, you know, making a diagnosis could be a little more, perhaps more difficult if we can't do the full exam in certain cases. But anybody have an experience there? I haven't seen one yet, but, you know, I'm sure maybe coming in the future, but we'll see. So let's pivot a little bit now. Obviously, the other side, you know, there's revenue and there's expenses. So on the expense side, we've gone through some changes. Obviously, there are cuts that are being planned. Some of the cuts are institutional wide. Some of the cuts are stratified by departments. Some cuts occur to faculty and physicians, and some cuts have been to staff. Some cuts are dealing with furloughs versus, you know, lack of, you know, cost of living increases. So we want to go around a little bit, and I'm going to start with David. What's happened, at least in terms of faculty, for salary at your place?
So all the chairs across the board were asked to take a voluntary 20% pay cut, which didn't feel very voluntary. It was for 3 months, and everybody did it. We were asked to look at our faculty, and anybody that was paid at the 75th percentile or above, we were to ask them to take a 10% pay cut for 3 months, which we did.
You only did it for 3 months. 3 months.
For 3 months, exactly. And in actuality, that didn't really save very much money for the institution across the board compared to things like the CARES Act, which really did kick in. And it turns out that it was probably more symbolic than anything that everybody, because we had staff that were being furloughed. It didn't seem fair to them that they were being furloughed, and you had, you know, wealthy doctors, if you will, that were making a lot of money. So I think symbolically it meant a lot to a lot of people. What it actually did for the finances of the institution, I don't think it was very much. Right. We were talking about having across the board cuts of 1% to 5% for all the faculty, but we didn't end up having to do that because of the reimbursements that we've gotten from the government. But they did take away our retirement contribution.
Right. I'm going to talk about that. So they did it at BU. So for the whole year or for a shorter period?
Indefinitely.
Indefinitely, yeah. And there's been many institutions. I remember I read about the first time was at Hopkins, but at our place too, they immediately decided for our new fiscal year, no institutional contributions to the retirement plan for everyone. And that's also people at the university non-medical, and medical. And that was a big, quote, savings and a mitigation for the expense reduction we felt. And then we had some salary cuts, voluntary for about 10%, a little longer than 3 months though. And then some others that we have to be thinking about in the faculty. But, you know, Wisconsin is a great example. You prepared for a surge, and Kathleen, you were telling me you were all ready, you shut everything down, and then a big surge didn't happen. Yet there were financial repercussions of that. Tell us a little bit about what's going on with faculty and leadership at University of Wisconsin. Unmute. Yep.
That's exactly what happened. So we shut everything down very quickly, and then and we sent everyone home with full pay for a couple of months. And then in April, we started to look at the numbers a little bit more, and we had lost quite a bit of money. And then we put together the package to fix that, including the CARES Act, et cetera. And then it was determined that the faculty should come up with approximately $9 million in savings. Expense savings. And so we had a temporary base pay adjustment for not just the faculty, but also everyone in senior administration took a 20% pay cut for 2 months. So about a 3% total, and it's retroactive. So this was in May and June. So it was meant to balance the balance sheet for FY20. And then the chairs also took a 20% pay cut for 2 months. And then all the administration and the chairs agreed to not get any kind of performance bonus. So on average, the chairs took about an 11% total retroactive pay cut, probably similar for the administration. We had a couple of sticky wickets, so people on guarantees aren't legally required to participate in anything like this. We did ask everyone on guarantees, and in our department, everyone agreed. Other departments, some people on guarantees did not agree to the pay cut, meaning other people in their departments had to take the pay cut. As it turns out, we fared better than we thought because we were able to reopen quite well, and we were anticipating a negative 9% operating margin impact in FY20, and we pitched these repairs to come in with a negative 3% operating margin, and we came in with a negative 0.8% operating margin. So we actually did better than expected.
So good, so good. Yeah. And then, you know, we've heard that some haven't had anything. So Andy, what about UCSF?
Well, we haven't had any cuts. We have a faculty salary freeze where faculty salaries from FY20 were projected to FY21 without an opportunity to negotiate any adjustments for cost of living, et cetera. With some rare exceptions, we do a deep dive every year on diversity to make sure along sex and rank and gender and race, we're doing, we're being fair. Those could allow for slight adjustments, but in general, it's been flat to the year before. Many of our faculty who are clinically active receive a bonus at the end of the year based on their RVU production. We'll see whether those have gone down. They probably have, but just minimally based on the data I described earlier.
Right, so we have the same thing, no salary increase in the new fiscal year. We have this Y, which is your incentive, and they were going to do the incentive based on the first 3 quarters of the last year and then average that out. That's what they're claiming they're going to do, and we haven't seen it yet, but that's the plan for our incentive plan. So we'll see, but no increases either. Sal, how about you in Texas, where now you're having more of a surge, but have there been cuts?
Well, we're in West Texas. We're doing a little better than Houston, but nevertheless, we're being fortunate here in that it was planned, or there was forecasted that the university as a whole was going to have a deficit for next year. So fortunately, they made cuts at the university campus level. And I'm not aware of neurology, or I'm not aware that the School of Medicine faculty were asked to take a pay cut of faculty or staff. The only thing that happened is that every year, and correct me here, Vinny, there is usually a 2% merit increase, and that was going to be frozen. There was not going to be such thing. We didn't have the issue about contributions to the retirement plans either.
Oh, that's great. Yeah. So it has been very heterogeneous, depending on different areas, probably depending on the financial security of your individual system, whether you're university, whether you're state, and other ways. So it is different. I know I've talked to friends and colleagues in New York, and New York who had a huge surge. I haven't heard of major cuts there either. So again, we encourage you to put in questions. I want to turn a little bit now to the staff, because there have been staff changes at our place. Potential furloughs at the main campus. All furloughs have already occurred, but at the medical school we were about to, and now they've been put on hold because we're having a resurgence, and some of these people that we were going to furlough are needed to even be redeployed. But maybe hear a little bit from Sheila on the staff side. Anything happened in terms of financial mitigations and impact?
Yeah, so we were actually given a target for the number of staff that we needed to furlough, and we ended up furloughing in mid-April about 30% of our staff across the board. We did it in essentially just one wave, and that was clinic-based staff as well as department-based staff. And as we were able to demonstrate growth in volume through our virtual visits, we were able to request to bring staff back, which I thought was a very equitable process. And by mid to early July, we had returned most of our staff.
That's great. And a question has come in about retirement match, and I think I guess we heard from, I know our place, no retirement, no institutional contribution to retirement for a year. And I think I heard that at, was it BU? You said that? Yeah. So somebody had asked about that in terms of that match, and it was suspended. Back to staff. Greg, what about at Wisconsin? How did the staff fare?
Well, here at Wisconsin, our staff are employed either by the practice plan or by the university. And both had their own systems of dealing with it. Initially, the staff employed by the practice plan are nurses, nurse practitioners, physician assistants, people working in clinics. There's some people within the department and the coders. All of those, we were given a target that each department had to meet.
Right.
People were able to flex time, which essentially meant they could either take paid or unpaid time. Because their PTO is actually paid as it's earned. So as you also had the opportunity to request, if your volume went up or if there was a demonstrated need, to request that your target be lifted, which we had to do with our coders, because the volume of bills that were coming through, we would just not have been able to deal with it if we had flexed our coders down completely. On the university side, those things on the practice plan side happen in May and June. At this point, they have not said that there's anything going to happen going forward. On the university side, on the other hand, where all research staff, at most of the administrative staffs within the department are employed by the university, there they've implemented a furlough system where it's actually an unpaid day that people have to take, and ranges from 3 to 6 days between middle of May and October that people have to take off, and
unpaid or paid?
Unpaid. It's
unpaid furlough time, yeah.
Yeah, because at the university, our vacation time is not paid as we earn it. It's a expense as it's incurred, and so that's something that they're saying right now through October. But just the other day, the university came out with something saying that they are expecting additional needs in terms of reductions.
Yep.
We have supposedly a 2% merit increase coming up in January. They have not taken that off the table yet, but nobody realistically is thinking that we're going to have that 2% increase.
And Vinny, how about you? I know we heard from Sal that at least faculty were okay. Any cuts in staff in Texas?
The staff was retained. In fact, there were no cuts. They did not get any merits at all. However, we did have pre-COVID empty slots or vacant slots. And so as long as we were able to submit a balanced budget with them included, we were allowed to go ahead and replace them. And so that it has been a little bit different for our department.
Okay. And then Jane, a large institution, and I know Jane, unions sometimes play a role here. What about at UCSF?
Well,
UCSF
I
side?
think, you know, putting this in context, UCSF is part of a large system, the University of California. And back in March, the president of the UC system announced that for every employee and faculty, there would be 3 weeks additional leave called COVID leave. It wasn't funded leave, so to that extent, it was like an expense to the departments, but I think
unpaid.
it's paid COVID leave, 3 weeks leave. If you needed to take leave for yourself, to quarantine, to take care of a child, I think it was a strategy. With hindsight, it was kind of a strategy, I think, to stabilize people so that people understood that, you know, their jobs were not going to be in immediate jeopardy. Also, there was a notice from UC that there would not be any layoffs through June 30th.
Right.
So it kind of put a pause for everybody so that people didn't panic. It is really hard to recruit and retain in California, so it stabilized things. That gave everybody time to put forth plans for if there are cuts to come, how would we do it? There were no salary increases for staff.
Okay.
However, there are a lot of unions in the UCSF system and UC system, and those are contracts, so those people are getting raises that were negotiated. So I think that it is a balancing act when you have a part of the workforce that's not going to get anything that's not unionized, but then the union people do. So I think it's a careful balancing act. But so far, I think it's been a stabilization and really to see what do we really need to do. Back in 2008, there was a huge furlough for the recession, and they proved it didn't save a dime. It didn't save any money. So they came right out and said they weren't going to do that again. Complete waste of time.
Right. No, that's a good point.
Health system, yes, they are much more stringent right now with position control and potential layoffs there.
Right. Yeah. So similar circumstances. And has there been a concern? You know, a lot of the concern for us was a resurgence and almost an anticipatory potential mitigation or cuts because of the concern of it hitting again and what the financial repercussions may be down the line. Did that factor?
Well, I think because San Francisco was so ahead of the curve in terms of the initial surge, that the whole Bay Area has worked a lot of that out. Andy could speak to that, but I think there's just not that fear that was from the first surge.
That's good to hear. That's wonderful.
Do you agree, Andy, with that?
I do, Jane. I also think, as I think most of the institutions who are on this, the idea of when it surges again, we're simply not going to shut down completely like we did the first time. I heard Ralph on a call yesterday, he can speak to it, say despite Miami's surge, there's still a part of the hospital doing all the elective stuff. That is very different than what we were dealing with in March and April.
We basically have 2 hospitals running. We have the COVID hospital running and then the non-COVID. So the electives had continued, the surgical input is continuing. At our county hospital, it's been different. There we had to cut back on some of that because the surge was much bigger. But you're right, we're more prepared. We have the virtual going strong, and I think our resilience when another surge comes will be stronger. There's another good question that's come in that I want to share that really talks about maybe something on the AAN side. You know, with all this happening and our healthcare colleagues really being heroes in the media, and you know, when they hear about cuts to MDs and cuts to staff, particularly those who could be in the front line, you know, this could be considered outrageous. And I guess the question comes in is, should the AAN advocate in helping the public know about this out there? And then could there be a battle cry for don't cut the MD salaries? It's a nice idea. I mean, there are many things that we advocate for, and this could be something, but it isn't just neurology. It is all healthcare systems, and it goes across all groups. But I think it seems it's very heterogeneous in terms of the kind of cuts that have occurred. I want to then pivot for the last minute a little bit about planning for the future, which is recruitments. Now, there's still needs. We all had plans to expand certain things in our departments. What kind of strategies maybe have been successful, have you tried to use to lobby institutional leadership in terms of recruiting, say, new or replacement faculty due to COVID-19 hiring freezes? And I'll start with Sal. Any thoughts there in terms of recruitment?
Well, I mean, I'm 7 years into my tenure here as chair, and I still have some money left. So, and fortunately, through these 7 years, and due to the contracts that we had, we were able to put some money sort of in the bank, if you will. And so we were advised not to use it, but if we need to use it, we just need to put a good business plan where at least we break even, so to be able to hire. So we can still recruit.
So you're still, you even though you have some quote salary freezes in there, your recruitment plan is on track.
It is on track as long as I have a good business plan for what these people are going to do. Yeah.
I know at our place we have to go through a couple more hoops, and they want to review things, and we have what's called JOLT, Joint Operation Leadership Team, that reviews it. And some of our recruits have been pushed out. You know, I had a couple plans, particularly fellows that were making transitions to faculty. I moved them a couple months, and then they were okay to get through. I had a chief that already had signed. He's coming. They said, fine, that's no problem. And then I had another chief that wasn't yet planned. So that one, we're just moving the timing out a bit. But Kathleen, what about at Wisconsin? How are you handling, say, your recruitment plans?
Well, we are the state, and oops, I do this every time, don't I? Oh no, I'm unmuted. We are undersupplied with neurologists in the state of Wisconsin, and it's a bit of a crisis. So we have a fairly steep growth projections and recruitment strategy. We were asked to go through an exercise where we said which of our recruitments could wait and which couldn't wait. We have a lot of open positions, so those ones that we aren't having a lot of applications for, they can wait, but that's happening anyway. And I think a bigger challenge is not being able to bring people on campus, not being able to interview people in person, but not so much from the institutional side.
The logistics of interviewing, you know, I think, would you hire somebody with just virtual interviews? That's tricky. And Andy's shaking his head, yes. Would never even meeting the person in person. You would do a hire just with virtual. I mean, we're going to be doing that for residents.
We're doing it for residents and fellows.
Yeah.
I think it's fine.
Okay.
I mean, we've had, Ralph, I'm sorry, Kathleen, we've had, you know, basic science recruits who have given their seminar for the neuroscience graduate program over Zoom, voted on. I think we have to just adjust, and I don't need to shake, I think I'm not supposed to be shaking anyone's hand from now till eternity, but I certainly don't need to shake someone's hand to be able to hire them.
Okay, well, that's good. And then Andy, were there any hiring issues for, I mean, I know you haven't had cuts. Sounds like you're weathering.
We have a hiring freeze for both staff and faculty, but just like you, it just requires a couple extra steps and generally requires a number of things. You have to have the funding, as Sal was getting to. It has to have a reason. If it's being done clinically, the health system has to sign off on it. So a little less freedom, but we're still able to do recruits for essential positions.
So to justify them as much as can. And David, what about at BU?
We've been able to recruit as long as it fits in with the finances of the department and with the hospital. We can replace positions. We did have to retract some offers that we had out to build up money losers.
A signed offer.
Yeah, actually, yes, we did. It was very embarrassing, and this is with, you know, people who are memory recruits, neuropsychology, that it was going to be a stretch to make them whole, and we were pretty proactive about it. Thankfully, these were people that were very understanding of what was happening, and they had backup plans.
And it wasn't, you could just push them out longer, like, and delay their recruitment?
Yeah, well, I mean, we parted on good terms, I'd like to say, so that I said, when this all blows over, we'd still love to have you, and they'd still like to come, I hope. But, you know, it's so hard to recruit good behavioral neurologists unless you're at UCSF, of course, and he's got a luxury of riches out there. But it's very hard for the rest of us to recruit good memory people.
Yeah.
It's tried for 3 years, so it's like heartbreaking when you have that fall through.
So for us, if we had a signed offer letter, I will say, they were understanding, and I didn't, and I did have one signed offer letter that was a higher level chief, as I said, and all they said was, can you just move it out a couple months? And we did, and that was fine because, you know, they wanted to honor it. But it depends on the recruit, depends on the financial circumstances. What about to budget planning in the remaining few minutes? And I know we want to end. Jane, I want to turn to you. Big UCSF, diversification. How have you handled some of the budget forecasting moving into fiscal year 21? Recognize that, you know, when is this vaccine going to be available, and how do we forecast for the budget moving forward?
I think it's very challenging because nobody knows for sure, but we did have our regular budget cycle, and then we looked at that with our different scenario planning, and then on the health side, they revisited even the 10-year plan, and just to see if they wanted to hold firm or not. So they're really making global assumptions. They're not really looking to the department to say, well, this is going to go up and that's going to go down. It's much more. We had already put in our plan, so now they're sort of making more sweeping assumptions.
So we put in our plan too, that was a pre-COVID plan, and then we're monitoring it each month to see how far off, what's the margin looking like, depending on what the COVID plan.
I think our biggest unknown in neurology is we have a big neurosciences building was due to be completed by now, but with COVID, all construction was shut down with the shelter in place, and it's taken a while to get back up and running. So now, you know, the health system thought, oh, we're going to have, let's say, open last July, but now it's pushed off to December, but now it's going to be February. So that's a real unknown in terms of
our capital improvement projects, including new healthcare facilities that was planned, have been pushed back, and the timeline now has been extended. We didn't touch on endowments, returns, research revenue. As you said, some research is going strong, especially if it's COVID-related, administrative supplements out there, and other things that are research-related. You know, the NIH funding is up, CARES funding, which are other revenue sources. There are many other things that we could have touched on. Unfortunately, I think we're running out of time. Any final parting comment? I think for all of our listeners out there, there's obviously a lot of heterogeneity in our departments. I hope some of the things you heard are ideas that you could pivot in terms of new ideas for revenue and ways to handle expense reduction, from whether it's in California, Wisconsin, Boston, Miami, or in Western Texas. Everybody is trying to come together and hold together as best we can.